Thank you very much. A pleasure to be here. I thank Mehdi and all the organizers. It's a great conference, a great opportunity for real learning. Really appreciate it. So imaging a patient with PVD, let's start there. What's the goal? Why do we image patients with PVD? I think it's really want to make that distinction between vascular, non-vascular disease and symptoms. We want to figure out a baseline to monitor, and Mehdi already spoke a little bit about that. And to get an idea of the severity of disease and the anatomic levels. It's going to help us decide how, if we need to treat, how we're going to treat, and which way. Many years ago, this algorithm came out, and basically it said if you had CLI, you're going to image patients or get some type of imaging study once you decide that they're a revascularization candidate. So really, that's who we're looking for, and I think that's still the same. What's interesting is that over the years now, this big area of medical treatment or amputation has really gone away, and we see more patients going to revascularization. The hallmark, I think, in the center of any imaging evaluation is a non-invasive examination. And at our institution, we consider it really 4 parts: an ABI at rest, PVR with segmental pressures, including evaluation of the digits with TBIs and toe PPGs, ABI after exercise, if the patient can exercise. We have a treadmill for 5 minutes, if they can tolerate that. And then after that, we do a Doppler ultrasound evaluation to get a Doppler map. It really gives us an assessment of the extent of disease, location of disease, and then try to get an idea of that tissue toe perfusion. And I think you've already gotten the gist of what I'm going to say in terms of the value of ABI, particularly in CLI. And I think CLI really becomes a clinical diagnosis. Once you suspect this patient has a wound that you think could be related to hyperperfusion, we go ahead and proceed with our revascularization strategy. And really is because of this data that Mehdi just presented about how we can't rely on ABIs. You're going to get too many patients with near normal ABIs. And you already saw these guidelines, and it's interesting, they start with ABI, and at the end, it's really anatomic assessment. And that's really what I'd like to speak about, why we go ahead with anatomic assessment. The last portion of these ABIs and TBIs is the Doppler map. And I want to say this is really a critical adjunct to a non-invasive study. It provides not only anatomic and morphologic information that we can get from a CTA, an MRI, or an angiogram, but there is physiologic information in that Doppler and that duplex ultrasound that you should be able to correlate as you're doing your procedure, doing your angiogram, doing your intervention. If you see a high velocity by duplex, I go back and look at that area. If I don't see it, am I missing something? If I see my waveform is going from a triphasic to a monophasic waveform, there is something there. I may not have seen it. I gotta go back and find it. So I really think that's an important point. So when do I acquire these CTA and MRAs? So many people say, Tino, I don't understand why you get so many CTAs and MRAs in Miami. Why do you do this? And I think it's why. The questions are why and how does it help? Really, it's important to look at a treatment map. We look at it to really understand the extent of disease, and it may not tell us the tibial and pedal disease, but it will definitely give us an idea of the inflow disease and help us plan our treatments. Where are we going to access? What are the vessel sizes? What are the risks? When I speak to the patient, hey, I think we're going to need to recanalize or revascularize the entire SFA and popliteal. The risks there are significantly different than if I'm just doing tibial work, and I think that's important. And at the same time, I can already assess, is there bypass targets? Is this better? Is this a patient that should go to surgery? And we do that really a lot of times off a good CTA and MRA. At the end of the day, I think it reduces procedure time, contrast, and complications. And I haven't been able to show that, but I think it would be a great study. So what does it help me? In this particular patient, not a CLI patient, but a PVD patient, I can see a calcified aorta, calcified iliac vessels. The access vessels are significantly compromised. The occlusion goes all the way up to the renals. This is a patient that I will recommend an aortal biiliac surgery and revascularization. What do I like about CTA? So the modality of CTA itself. A lot of people get CTAs because it's easy, it's accessible, it's everywhere in every ER. You can just say, let's get a CTA. Well, it gives you high spatial resolution, and that allows us, a big radiology term is isotropic. It gives us images and voxels or points that any way I look at them retain their measurement and their fidelity, so that I can do reconstructions in multiple different ways, whether they're curved planar reformations or what we call skewer views through the arteries, and really preserve that information. But it allows me to look at the whole tree, not just the lumen, but is it calcified or not? Is there soft plaque? Give me some idea of positive remodeling. All these things are important a lot of times in the vessels that we treat. And then gives me some idea to evaluate patients that have stents. You can see this patient had a jump graft to the right popliteal artery to the TP trunk, and you can see that on a CTA. And then we can see, and we were concerned about maybe some narrowing stenosis, patient had an angiogram, you can see how well they correlate. So really get good information. Study done years ago showed that with a good CTA, you can really evaluate a patient and decide, does this patient need medical management, patient needs surgical management, or endovascular management, which I think is important. You see this particular patient you want to treat. The CTA showed you really dense calcification in the common femoral artery. That patient went to surgery and endarterectomy. A more complex patient with non-healing left foot ulcer. You can see the extent of this iliac disease involving the common femoral artery. We were able to talk together in terms of with my surgical team and say, okay, we want to do a hybrid approach. We went ahead, first thing we did was go from the right groin, come up and over, and be able to treat that common iliac artery, establish flow into that common femoral artery, and then set the patient up in a later date, if he needed it, with a bypass, FemPop bypass. Again, allow us to treat these patients. What about CLI patient that's special? And that is a lot of infrapopliteal disease and really extensive infrapopliteal disease. We know a lot of them have occlusions and very large segment a long segment disease. In CTA, if we get a good evaluation, which sometimes is limited in patients with a lot of calcification, we can define the level of disease and then go ahead and plan treatment, as in this case, where we performed some atherectomy and angioplasty. But really, the challenge of CLI patients is the calcifications, and it really limits CTA evaluations. Between the vessel calcifications and patient's renal function, really holds back the advantage of a CTA in these patients. So a lot of times we go for MRA with time-resolved imaging. MRA, again, not using radiation, but this requires gadolinium. And what we're doing is looking at a 4D evaluation of the tibial vessels. It gives us an assessment. Which tibial vessel is dominant? Which one is feeding through collaterals? Is there retrograde filling through one of these? New techniques now have allowed us to perform these studies faster. So M-Dixon is just a type of sequence that allows us to basically do these images now in half the time because we do yet less subtraction imaging, less patient motion. But I think it's really important when you look at these types of time-resolved imaging, because I think this is really the crux of where we're going to go with CLI imaging. You see this particular patient with some tibial disease, and you can see it here. You can see just the way there's diminished filling into that PT trunk. And as we slowed it down, identified that by this time-resolved imaging, when at the time of angiogram, we knew exactly what we wanted to treat and how we're looking at it. And a lot of times we're now looking at hybrid MRAs, performing a standard MRA and then performing that time-resolved to look at the tibial pedal vessels. Again, that value of being able to acquire this volume of information over time, and then you're able to say, let me look at the right foot and really figure out that DP is occluded and you're filling through a compromised posterior tibial and common plantar arch. And then being able to evaluate these. I'm running out of time, so I'm just going to skip a little bit, where I think a take-home point is further sequences now are really helping us. I really think the next level for us to do CLI is understanding that pedal circulation, understanding which patients have dominant filling through the lateral tarsal, which have common plantar arches that are the dominant vessels. And being able to acquire sequences such as this, I think will help us pre-plan for these patients so that we know going in what to expect and how we can help them. In conclusion, there is some work on non-contrast MRA because I think using gadolinium in these patients is limited. You can see what it looks like in normal patients in 6 and 10 minutes, and then patients with severe PVD and CLI. Again, work is being done with this. I think it's going to help us. Why I order, I think I pretty much told you why, and choosing which one I really go for an MRA examination when I can. Thank you very much.